Okay, so I thought I would talk specifically about hemodynamics and shock, and we'll start off with targeting assessment to global and regional tissue perfusion, because of course shock's about perfusion, and there's steps we take when we actually look at a patient who's admitted who may or may not be shocked. And we start off with a clinical exam, we do basic monitoring, and we sort of up the ante as we do things bit by bit by bit. Assessment of preload, we do a little bit of minimal invasive stuff, a little bit of transpulmonary thermodilution, which can be done without a pulmonary artery catheter, with other means, and then the pulmonary artery catheter, which is actually the most invasive of all those. But some places use it as a first line, one of the first line measures too. So we'll go through that. So clinical exams are fastest and least invasive monitor available. And if you look at your patient here, a lot of the clinical signs that you can see, I mean, of course you have the monitoring, but the patient colour, the way their peripheries feel, you can see their JVP, you can look at the colour of their tongue and their gums and mucous membranes. If they're not sedated and awake, they may have some sort of anxiety or some anxiousness and some restlessness, which may be to do with perfusion and inflammation to the brain. Because all conditions, all critical illness has that inflammatory effect to the brain. But one thing I want to see here is that this chap's actually got an ostomy, and you can actually see if the gut's perfused. So that's really very useful, because remember, the gut's one of the first things that changes in shock. So that looks quite pink and it's functioning. And of course, something I didn't mention, of course, was urine output. We can see there. So clinical assessment is actually, you can tell a lot about what's going on, and we mustn't forget that. Now there's basic monitoring that we do on every patient. And the ECG or the monitor isn't a passive thing that we do, and it can pick up on global perfusion because your heart rate is something that responds to cardiac output requirements. So tachyarrhythmias are very common in patients that require or have some form of global perfusion issues. In fact, atrial fibrillation is one of the first things you will see in patients who have a massive inflammation response and have perfusion issues. We also have myocardial perfusion. You can see what's happening on your ECG at moment by moment, or your leads. You can see up here is a patient that has lead 2 and they have ST elevation happening there. And so you go along and you do your ECG and you find that you have inferior changes and anterior reciprocal changes. So the patient's actually having some infarction or injury there. So don't forget that. The third thing, blood pressure. Blood pressure target is patient specific. You've got to look at it at the clinical context of your patient. So one of the first questions you should ask about your patient is, what is their normal blood pressure? And what medications are they on that is modulating that? Maybe they're on beta blockers, maybe they're taking some ACE inhibitors or whatever. So you can see that blood pressure is part of the cardiac output equation there, and it also has something to do with the systemic vascular resistance, which reflects all those compensation things I was talking to you about earlier. But, and I'll keep clicking, it doesn't work. It also suggests that there might be some form of relationship with organ perfusion. But using blood pressure just by itself is an adequate therapeutic target, you must put it in the clinical context of your patient and their history and what type of shock they have. For example, if someone has hypovolemic shock, you would expect their diastolic pressure to come up and the systolic to drop. Whereas if someone has sepsis, you will often find that their systolic will stay reasonably okay, but their diastolic will fall away, and then the mean, that pulse pressure becomes widened. So it all becomes in context of the type of shock you're looking at. No doubt you would have looked at serum lactate as a measure of perfusion, and this is a study back done in 1991 when they first looked at lactate and were quite dubious about it. They didn't think it had anything to do with perfusion. And it's just two groups. There was one lot that had low lactate or normal lactate and one that didn't. And you can see that on resuscitation, those people that had an initial lactate which was lower than this group here, they survived. And their final lactate, which was like a few days later, had normalised. The ones that were the non-survivors, they didn't normalise their lactate. So for some reason the cell wasn't functioning to take up oxygen and the food that it needs. Okay. You can also take lactate not just from the arterial gas, but you can also do it as a venous. So they're both about the same. Alright, so if you do your clinical exam and you do your basic hemodynamic monitoring and you have what looks like as if someone's got some malperfusion or hyperperfusion there, then you need to do your assessment for preload. And what we tend to use as a surrogate for preload is central venous pressure. We could also use your JVP. We could also use right atrial pressure if we had a pulmonary artery catheter in. And you can see that we've got a trace there of the central venous pressure line, and it's 6 is normal for someone who's spontaneously ventilating. So that's all very good. And just something I want to say also about CVP is that we're actually using a pressure really to think about volume. So, and there's a lot of things that affect that volume. Okay, so it's only a surrogate measure, and we tend to use it over time more so now than just an isolated measure. We also look at central venous oxygen saturation. So you can have a central line in and do your CVP, and you can do your central venous oxygen saturation. It does, you can see the equation there, it's about oxygen content, oxygen consumption and cardiac output. That's what the equation is. So there's actually a lot we're looking at with regard to hemodynamics there, and some really sensible things like oxygen consumption and cardiac output, which are really good, strong things. So taking a central venous oxygen saturation is really a good thing to do, but you have to use it in context with everything else you've got. Often when people start with early resuscitation, they will have a low central venous oxygen saturation. Then it normally comes up to about 17. You'll find it'll stay there if the person's well filled. So, so it's in the index of global tissue perfusion. Now, CVP can also be measured by your echo. So you can see there the inferior vena cava. They've actually done the diameter of that, and there's your right atrium. And you can do that on echo, and you can see if it's quite filled, because the inferior vena cava is very thin-walled, and if it's not filled with blood, it will actually collapse. It'll collapse right on itself. So if you can see that on echo, then you know you're well filled. So, as I was saying earlier, CVP if you're spontaneously breathing, it's 0 to 5, but if you're mechanically ventilated, then you need to think about the added pressure from that, positive pressure, as we do. But if you have someone who has a CVP which is above 15, there's always a pathological finding for why that is. And a lot of our patients are becoming more and more like that, which makes this a little bit tricky to think about it in terms of normal context. So our new dynamic targets, we tend to do trends in CVP over time in response to fluid therapy, as well as doing the CVP you do when the CVP goes in. You do it, you know, every so often. And then we can go from looking at what the numbers are to, does this patient actually respond to some fluid, which is probably the next question we ask. Because it's not just about what the CVP number is. We've got to think about what that means in terms of the patient and whether or not the patient actually needs fluid, which is another question entirely. And will the cardiac output increase by giving fluid? Yes, then they are what we call preload responsive. And you can see here we have the curve, which is the, what curve? Sorry. Didn't hear you. Starling curve, yes, lovely. Stroke volume, just want to see if you're awake. Stroke volume on the side there, ventricular preload there, and it depends what part of the curve, and I'll explain that by looking here. Now this is a picture of someone's heart rate that's been, okay, so they've got a very slow heart rate, so we can actually see what the stroke volume is. This is done under some tests that they do with nuclear medicine. So you can actually see this component here is your stroke volume. Okay, so your patient here, everyone get that? Yeah? So at baseline, this patient had a stroke volume of 60, which is actually a little bit low. Yeah? What's normal stroke volume? You can see it here. No, that's stroke volume. Yep. If you look it up here, it says a normal stroke volume. Well, it doesn't, just gives you SVRI. Normal stroke volume is about 80 mils. Okay. All right. So then we give the patient a bolus of fluid, 125 mils, say. And the stroke volume actually increases to 76. Sounds good. Looks like we're patient's fluid responsive. And then we give 250 mils, which is probably closer to what we would do as a fluid bolus. And you can see the stroke volume's gone up a little bit more, probably a little bit more than what it should be, but hey, that's good. Looks like that's fine. The heart rate's sort of still pretty slow. Cardiac output's picked up a bit. And then we suddenly let the rest of it go through while we were doing something else, as often happens. And you can see that once we've got past 250 to 500, the stroke volume hasn't changed a great deal at all. So what does that mean? That means that we've actually gone up, 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 and we've gone here, where even though we give more fluid, we actually don't increase the cardiac output or the stroke volume. And in fact, if we gave more fluids, all we'd end up would be pulmonary edema. So the trick to this is actually knowing what part of the curve the person's on. And I've talked to you in the past about something called stroke volume variation, and we'll talk a bit more about it in a sec. But you can see if you've got a 5% stroke volume variation, then you're flat on the curve. If you've got one which is 12%, you're starting to sit there. 23%, you're a little bit more, and if you have a stroke volume variation of 45%, you're really crispy, and there you sit. Good. Now, something that you will hear people talk about is passive leg raising, because what that does, it actually delivers about 300 to 400 mils of blood to your heart if you lift up someone's legs. So that's one way you can tell without giving them all the fluid to see if they'll respond, which sounds good in theory. And you can see here a group of people. Both patient groups were very similar, and there was responders and non-responders to passive leg raising, and you can see they lifted up their legs and cardiac output increased and stroke volume increased as well. So an increase in stroke volume of about 12% predicted an increase in cardiac output in the same vein. So that was interesting. The only problem with passive leg raising is that our patients aren't always ideal to do this on. And sometimes we have, sometimes we've got patients we can, but sometimes we don't.